everyone, I'm Dr. Clinton Orsini with Connect 33 Upper Cervical Chiropractic. Today we'll be talking about sciatica. We'll be presenting a patient who had sciatica for a number of years. We'll talk about the x-rays that we took on this patient, the spinal issues that we were able to identify on x-ray. Then we'll talk about what we did to help this patient recover from their sciatica. So without further ado, let's go right into it.
All right. Here we are looking at this patient now. This patient, again, has sciatica as their primary complaint. However, we're still going to start at the neck because many people, even though they have symptoms in the low back or legs, still may be related to their neck issue. So again, we're going to start with the lateral cervical x-ray. This is the x-ray taken from the side of the patient. Eyes, nose, mouth, dental work, the atlas, the first cervical vertebrae, the remaining cervical vertebrae underneath it. We have disc spacing in between, which you can see is clamping down here at C6, C7. Also bone spurs occurring on the front of C5, C6, C7. So those are all things that we note to identify any spinal stress. Also, a more rare finding is they were in such a bad injury, we would suspect a whiplash type injury, and I'll tell you why we think that in a moment, but that this injury even caused the body to put bone in the soft tissues. So that is not a normal finding, that is an abnormal finding. However, it's just something that we note. As the patient flexes their head down, what we're looking for again is the spine to make a nice rolling curve, and these spinous processes, the tails of the bones, to all flare open evenly. One complaint that we see is at C4. C4 is not moving off C5 properly. C5 is moving off of C6 somewhat, and you could even argue C6 moving off of C7, which it does look like that. However, we also know that C4 is a mate to C6. C6 was probably the original trauma. Well, why would I say that? Well, we have soft tissue injury exposed right here with the hard tissue being placed on the soft tissue. We also have the disc degeneration and arthritis occurring at that region. So generally speaking, I suspect that C6 would be the culprit, and that was the culprit. However, we also need to note that C4, though may not have been injured by the original trauma, over time has been injured because this area of the spine is aberrant. When we take the spine backwards, we saw a lot of multi-level extension locks, primarily right here at the level of the disc degeneration and arthritis. So we were expecting a large number of areas problems or symptoms coming from this area. However, the patient doesn't have any real symptoms. You may be wondering what might come from the mid-neck. That would normally persist in the form of neck pain, maybe upper back or trap tightness, but a lot of times what we see over time is this producing numbness, tingling, weakness into the upper arms and specifically the hands. However, when this patient takes their head backwards, the spine does not close, and this is the area that we have to address. The C5 not closing on C6, C6 not closing on C7. We also probably worked on the dorsal spine as well. Oh, well, we did work on the dorsal spine as well, but the primary issue has been identified at the C5, C6 level. We are now going to go into our alignment films. This is the first x-ray, the vertex, which this was when I first started the clinic, so these are not my most pristine x-rays. I will show you more pristine x-rays in the past. However, there is a reason that I'm showing you in this case, especially with the flexion film, where we can show our results. However, on this patient, when we do our analysis, we can see the first vertebrae rotating forward on the left side. That's the important part of this film. The next one is the nasium, which again is not properly taking. The atlas should be at or above the center of the film. And these head clamps are even a little bit high compared to the atlas. So in general, this is not a very well taken film. However, we were consistent from one film to another, staying consistently bad on the films. So we at least try to compare apples to apples when dealing with x-rays. After we put down our points that we'll have to cover in another video, we can see the head leaning over to the left side. That's actually represented right here on our analysis box. We can see left leaning of 3.25, 3¼ degrees leaning to the left. We see the atlas right here, the bow tie structure that is leaning down on the left side compared to the gravity line right here. Of course, if your head was sitting on a level surface, that level surface would be symmetrical or parallel with the horizon of the earth. So that's why we use that line to say theoretically the atlas should be at a level marker. And then we can see the rest of the spine leaning down from left going to right. So in our analysis world, this is an opposite angle. We have two acute angles, on the acute angle on the top side, acute angle on the bottom side. However, we call this a NUCA type 4 because the head, instead of leaning to the right, is leaning to the left. Why do I say that? Well, if the neck is leaning to the left, the head should tilt right. Actually, vice versa. If the head was tilting right, the neck should shift left to keep the eyes on top of itself. In this case, the head is tilting left. We would expect the spine to shift to the right to keep the eyes on top of itself. That did not happen. So theoretically, what happened is the head used to lean right. The spine shifted off to the left to compensate. Another trauma occurred, hitting the head from right to left, putting us in this aberrant position. Again, this was suspected to be our primary complaint with sciatica in this case because with the head and neck both leaning to the left side, the muscles of the back have to balance itself off to the right side to try and pull all the structures back to normal. So that was just a clue in that we had. Lastly, we have the A to P view of the lumbar spine or the pelvis. We did not get a lateral picture on this patient. I was still trying to figure out my x-ray machine back when I first opened this clinic. But the high points being the film is showing that we're lower on the right side. We have the hips and femurs lower on the right side, and the whole spine is tilting off to that right side. If I put down some more updated markers, you can see that the spine is tilting off to the left on the bottom or off to the right on the top. Basically what this tells me is that I have to work on the right SI joint. I know that based off this analysis because everything is leaning down to the right and more pressure is being put on that side, as evident by the spine leaning off to that right side. So on this patient, even though the sciatica was on the left side, we had more right-sided issues spinally, and we did have to work on this right SI joint. So backing up a moment, we did say we had this initial picture of the nasium. We wanted to make sure that we fixed this picture, so we always go back and take a secondary picture after the first treatment to make sure that we've done the job that we thought we did. When we went back, we saw the head and neck had propped up to a very good position. Again, I want to reiterate that this is not a properly taking x-ray. However, it is very similar or congruently improper with the other film. So that's why we're trying to compare apples to apples, not apples to oranges. As we can see, though, that this case has propped back up to normal. The atlas went up back to normal. The head shifted back more to center, and the spine shifted back over to the right side. So overall, a very positive adjustment. You may be wondering, how do we know if an atlas adjustment or an upper neck adjustment is needed? Well, when this patient first came in, they had a right short leg laying on their back by 1 full inch. When they stood up, their hips went 2 degrees low on the right side. After we did the initial treatment, we took this post x-ray. Before we took the post x-ray, we had to make sure that we actually had done our job neurologically, or knowing that we at least had taken some pressure off the nerves. We saw that by that right leg of 1 inch short returning back to normal, so they were balanced, and the hips of 2 degrees returned right back to normal of 0 degree malalignment. We are talking about the muscles, of course, not the osseous structures. That will maybe be a video for another day. That's too much information for you right now, just knowing that on the post x-ray, it came back to normal. We had the low back as a primary complaint. We wanted to make sure that we were doing a good job. These are confirmation films to make sure that we are adjusting on the correct side. As I initially told you, or you saw, should I say, you had a lower hip and lower femur on this right side. The spine is tilting off to this right side and then shifting back to the left. That tells us, again, that it's a right SI joint problem. However, we want to make sure. So what we do is we put the spine in motion. When we have you lean to the right, these tails should cross over to the right side, crossing the midline, going all the way over to the right. When you lean to the left, these bones should slide more over to the left, or pretty much how they already look on this base film. When we leaned them to the left, I apologize for the poor film quality on this patient, but things were already that way, so we weren't concerned. However, when we move right, we can clearly see that the lumbar vertebrae as a whole, actually as a whole unit, are not moving to the right side. So that only confirmed that it was a right-sided issue. We needed to adjust the right SI joint, but also that we may have to look at these lumbar vertebrae as well and try and trust actually a large number of them to try and get them to rotate back to the right side. Now we're going to talk about what it looks like long term. So initially we had diagnosed that we had a C6 and a C4 problem. I didn't think C4 was the primary complaint, but C6 was, but we still needed to address this C4. Over the course of time we worked on this using our nerve scans, and we'll come back to that another day. However, this is the initial flexion film, then we take a post-flexion film. On this post-flexion film, this is a year later, we can see the spine opening up again. We still see the evidence of trauma. That's not going to get reabsorbed. However, now the spine is into a more rolling curve. It may not be perfect still, but again, there was a lot of trauma. We had disc degeneration, arthritis in the inside. Bigger point though is I want you to look at that C4 vertebrae and it's opening up. Same with C3. And we never even touched C3. I want to relate that. We can see C3 not moving as well. C4 was really more of the culprit, but we mostly worked on C6. Again, I just wanted to reiterate that. And this was the outcome. The C3, C4 moving properly, the spine not further degenerating, and these areas moving more properly. Lastly, we want to just make sure that everything's moving or sitting in the right position, and we do so at certain points in time throughout a patient's care. So initially they came in with the left-leaning skull, left-leaning lower neck. After the first treatment, we propped them back up to normal. However, this is when they're in alignment. So at a later point in time, we saw the patient out of alignment. I wanted to see if they even look anything like this. This is a new pre-film when the patient is actually out of alignment. However, it looks nothing like what they used to look like in the past. It looks a lot more similar to what they looked like when they're in alignment off of the initial treatment. So that is why we take pre-post x-rays to make sure we can get the most amount of correction possible, and why we take x-rays later to make sure that we're doing a proper job, we're getting the expected outcome, and if we're not, of course, change our methodology to try and get a better change. So if you like this video, I want you to smash that like button. Also, if you like this type of content, I want you to hit that subscribe button for other things like this. We will be covering more patients in the future. This is our first one, again, covering sciatica, with a patient who improved vastly over the course of time. And until next time, keep your head on straight.